Examination. We're going to first do finger to nose, so I need you to put your hands up like this, fingers open. When I touch the tip of the finger, I want you to touch the tip of your nose with it. But we're going to do it with eyes closed. Can you close your eyes, please? Go ahead. Okay, that's good. Open up. So normal would be, put your hands up. Normal would be every time you can accurately, consistently hit the very tip of the finger to the tip of the nose. That would with all fingers, except we don't test the thumb every time. Inaccurate would be inability to do that consistently. He will miss some, which will be dysmetria, so unable to target accurately with fingers on one side or both. Also, you might see us abnormal finding a kinetic tremor or intentional tremor as they approximate the nose. And you may see also a postural tremor, which is also a sign of a cerebellar lesion when they have their hands outstanding. The next one is heel to shin. Well, okay, let's do one more. The next one is rapid hand alternate movement. There's 4 positions, so let's do all 4 positions. Put your hands straight like this, fingers together, and alternate back and forth as fast as you can. And we're looking is for a uncoordinated movement like we can see here on the left side. That's position number 1. Position number 2, you're gonna bend at the elbow 90 degrees. Do that again. And we're gonna look for this coordinated movement. In this case, it's a little bit, actually it's on both, also on the right. And there's a reason why, because we're checking different parts of the cerebellum as we do that. The next one is here. I need you to flip, tap like this, back and forth. Go as fast as you can. And then switch sides. Okay, and the last one is do flip back and forth like that. So normal would be to be able to symmetrically and very well coordinated, be able to rapidly alternate the hands from supination to pronation. Abnormal would be the presence of uncoordinated movement, which is called dysdiadochokinesia. So it'll be a broken down of movement on one side or both. The last one is heel to shin. And heel to shin, go ahead and lay on your back. We do not want the patient to look at their feet. We're going to have the patient do the following. So I need you to, with this toe, heel, I want you to put it on this toe. Run the heel all the way to that toe. You can bend the leg to touch the toe. And then run the heel back and then put the leg down. Go ahead. Good. Now do it with the other side. Okay. Go ahead. Thank you. So normal is they're able to properly find the kneecap, run on top of the shin all the way to the toe and back, and keep the heel on top of the shin. Abnormal would be they might make a big arch, a big C, either to the outside or the inside. That will consistently miss it and make a big C. They may make a zigzag back and forth as they go back and they miss it. And the last one, which is a little bit less obvious, can I bend the knee? Is they'll start properly, but they'll drop to the Achilles and they'll use the Achilles as a hook. They'll touch the toe and somehow they'll find that Achilles again and they'll ride the Achilles up and then put the leg down. Any of those 3 are considered abnormal. So if you don't mind shutting that down, tell me when you're ready.
All right.
Okay, we're going to do pathological reflexes. We're going to do 1 in the upper extremity and 2 in the lower extremity. The first one is called Hoffman's. May I borrow your hand? So Hoffman's is we're going to secure the 3rd digit in such a way that only the dip can move into hyperflexion, which is Hoffman's. We're going to leave 1 and 2 free because these are the indicator digits, which they will approximate if there's an upper motor neuron lesion. You can do this several ways. You can flick the fingernail into hyperflexion, throw the dip into hyperflexion, or you can flick it into hyperflexion. Normal is no approximations of digit 1 and 2. Abnormal will be approximations of digits 1 and 2 every time you flick the finger. When you come to the side, make sure that you come appropriately and do not block 1 and 2. So you're going to secure it over here, and then, thank you, you're going to hold the hand, and you can either flick it or flick it this way, but it has to be done into hyperflexion. So that's Hoffman's. Do you mind laying on your back? The next one is going to be Babinski. And Babinski and then Chaddock, which we'll do next, have the same findings. So let's do Babinski. The first thing is to hold the tool with good control, so it needs to be held very proximal, not distal, so you have good control because you're gonna make a 7. You're gonna make a 7 lateral foot and then come across the ball or the this part of the foot and making a 7 and a backward 7 on the other side. You're gonna secure the ankle, come in sharp, and you're gonna go like that. And then you're gonna come to the side. So that was normal, because normal is either flexion of the toes or no movement of the toes. So that was normal. Abnormal will be primarily extension of the big toe. Sometimes this will flare out, sometimes it will extend as well, but the key indicator is flexion of the big toe. That's what makes it abnormal. Chaddock has the same findings, so normal and abnormal are the same as Babinski. In this case, we're gonna make a C around the lateral malleolus. We're gonna hold the tool the same way. And we're gonna scrape around the lateral malleolus from proximal on the lateral malleolus to underneath to distal, aiming toward the 5th digit or 5th toe. And we're gonna scrape a C. If he had an upper motor neuron lesion, we would extend the toes just like in Babinski. Okay, and that's Chaddock's. All right, let's stop that. We're good? Okay, the next examination is for the cognitive exam. The first thing we're going to do is orientation. Would you please state your name?
Andre.
Where are you at?
Parker University.
And roughly what time of the day is it?
2.
Okay. And so he normal would be he's able to properly state his name, the place it's at, and the time of day. Abnormal, it would be that he misses one or more than one of them and not able to complete the test. The next one is called attention and calculation. Could you please spell the word world forwards and backwards?
WORLDDLROW.
So normal would be that he's able to start and finish correctly without misstepping any of the letters and completes it at a reasonable period of time without mistakes. Abnormal would be the inability to start, the inability to end, make too many mistakes, has hesitation, beyond normal. That would be abnormal. The next one is also called attention and calculation. This time I need you to count backwards out loud from 20 by threes.
Okay, 20, 17, 14, 11, 8, 5, 2.
Okay, good. So normal is just like the other one, is he's able to start and finish in a reasonable period of time without making any mistakes. Abnormal would be the inability to start and the inability to finish, or making too many mistakes along the way. All right, that's all right. This is proprioception. Would you please stand up, and as you do, pull away from the table so you're not touching it. Put your feet together as tightly as possible. Look at the wall. No, open eyes first. Hands to your side. Close your eyes. All right, good. All right, go ahead and sit down. So normal is being able to stand with feet together, eyes open and closed without sway. Abnormal, with feet together, hands to the side, they will sway to the side of the vestibular lesion. That would be abnormal. If there's a swaying, that would be to the side of the vestibular lesion. The next one is position sense upper extremity. So may I borrow your hand? Okay, we're going to test digit number 4, and make sure that when you do the digits, either they hold the fingers apart or you spread them with your other hand so that they're not touching. And also when you move the digit, that you're not touching your own fingers or their own fingers as they're coming up and down. You must hold the fingers on the side, not on top and bottom. This is inappropriate technique. To the side. And then this is how it goes. What I'm going to do is I'm going to hold your finger up. Look at this. Up. Neutral or down. And you're going to tell me where it's at. We're going to do this with the eyes closed. Could you close your eyes? Tell me where it's at.
Up.
Tell me where it's at.
Down.
How about now?
Down.
How about now?
Down.
Okay. May I have the other hand? Keep your eyes closed. Again, make sure the fingers are apart. Okay. Tell me where it's at.
Down.
Tell me where it's at.
Up.
Tell me where it's at.
Up.
Tell me where it's at.
Down.
Okay. So go ahead and open your eyes. So normal would be for the patient, whether it's, again, the same thing for the toes as well, where they can hold, they can tell accurately using the 4th digit if the finger is up or down every time. We will not test neutral. This was a distractor, so we're going to test up or down. And abnormal would be where they have no idea where the finger is up consistently, or they make too many errors. Okay, so now we're gonna do the lower extremity. Again, using the fourth digit, we're gonna use our hand to spread the other toes apart, okay? And we're gonna grab the fourth digit by the side, and then we're gonna make sure that the patient's not looking, so close your eyes. Okay, it's again up, middle, or down, so you tell me where it's at.
Up,
Where's it at?
down,
Where's it at?
up,
Where's it at?
down,
Where's it at?
down.
Okay, that was a few misses. Okay, let's check this one. Again, make sure that before you start, you check to make sure the patient's eyes are closed. Oh, sorry about that, I'm missing that toe. Where's it at?
Up,
Where's it at?
down,
Where's it at?
down,
Where's it at?
up,
Where's it at?
down,
Where's it at?
down.
That was the lower extremity. That was position sense, lower extremity. Same findings as the upper extremity. Okay, that's that one.
Right. 3, 2, 1.
Okay, so next one is the vestibular system. So I need you to stand up and come right here. And keeping your hands to your side and looking straight at the wall, you're gonna walk in such a way that you're touching your heel to your toe in a straight line. So go ahead and start that. Eyes open, go. Okay, good. Stop. Now turn around. And we're going to do this now with eyes closed, okay? Heel to toe, eyes closed. Ready? Go. Okay, got you. Okay, go ahead and go have a seat again. Thank you. So normal is being able to walk with, in a straight line, heel to toe, with eyes open and closed with no sway. Abnormal would be a sway to the side of the lesions with eyes closed. That would be abnormal. Resting nystagmus is just the presence of nystagmus. You're going to tell the patient to look at that dot at the wall. We're going to stand to the side and looking for resting nystagmus, which he has none. And nystagmus can be upbeat, downbeat, left, or right. So here's what it would look like. So this would be a left beating nystagmus. So it would slightly drift to the right of the patient's eyes and quickly correct to the left. So this would be a left beating nystagmus. A right beating nystagmus would look like this, if this was the patient's eyeballs. An upbeat nystagmus would look like this. And a downbeat nystagmus would look like that. So that would be the presence of a nystagmus. Okay. The presence would be abnormal, non-nystagmus would be normal, right? The next one is the head impulse test. Do you have any problems with your neck that I cannot move it quickly?
That's fine.
Okay. So what I need you to do is look at that dot, and I'm going to move your head back and forth, and you're just going to keep your eyes on that dot, okay? We need to secure the head in such a way that we have control of the head. We're not adjusting the neck, so it's control over here. And we're going to start about 15 degrees from neutral. Make sure we don't block with our shoulders the dot. And I'm going to move it kind of quickly, okay? You ready?
Mm-hmm.
And we're going to move the head. Relax a little more, please. There you go. Thank you. I promise not to hurt unless you tell me. Okay. There you go. That was much faster. We're going to do it about 2 to 3 times to each side. Normal is the ability to stay fixated on the dot like he did when the head moving back and forth. Abnormal will be the presence of a saccade, and that will be a quick jump. And it'll be, if you see the saccade as you turn into the right, that would be a right lesion. If you see the saccade as you turn to the left, that would be a left lesion. Okay?